in and you are going to treat them with for an acute attack with colchicine, the first question you have to ask is, are you taking it on a regular basis? If they say no, then it's easy. It's the 1.2, think of it as a load, give them another 0.6 in an hour, you give them a 1.8 in the first hour, and then you can start them on 0.6 once or twice a day until the attack resolves. Okay? The problem comes in is if they're on prophylaxis, then you ask them, have you had treated for an acute attack in the last 2 weeks? If they say no, then you can treat them just like you did over here. If they say yes, then go to another drug. Does that help? I should draw it out like that. Okay, let's move on to page 13 in prevention. Okay, so prevention, patient education goes again. Okay, prevention comes in and people having multiple attacks. Then you need to put them on preventative therapy that will lower their production. Usually, we're going to go after production, or we're going to try to get them to excrete it more often. Most of the time, we go after decreasing production of uric acid. So we're going to educate them on lifestyles, all those things we talked about that we would do when they have an acute attack. We're going to try to eliminate secondary causes. In fact, I'll type this up and send it out to you. Don't worry about it. Trying to get it down. So you're going to treat their other diseases that may be aggravating the gout, get rid of drugs or replace drugs that are changing their uric or increasing their uric acid that you may not need, or that they could use something else that wouldn't aggravate it. Indications for pharmacologic uric acid lowering or prevention would be if they have tophi. There's no way to get rid of them unless you lower their production of uric acid and allow those to resolve or dissolve. If they have X-ray signs of gouty arthropathy. If they have more frequent attacks in a year, 2 or more. If they've got renal insufficiency, because then they're at risk for the gouty nephropathy. If they have a history of uric acid stones. This last one is a more unusual one. These would be in young people, young men or women who are excreting high amounts, so 1,100 milligrams a day. That's a really high amount because their risk of uric acid stones is great. So we have a target. So for this, the treatment target for uric acid is to get it below 6. In some people, you may need to get it below 5. It's fairly easy to accomplish this with the drugs that we have. Our preferred go-to drugs are the xanthine oxidase inhibitors. So they've been around, allopurinol's been around forever. So this drug inhibits the enzyme that converts hypoxanthine to xanthine in uric acid. Okay, easy. There are 2 in this category. There's allopurinol and there's febuxostat. Allopurinol is the go-to because it is very cheap. The other one's very expensive, but it does have some drawbacks, and we'll talk about that in just a minute. If you have someone who's young and excretion is the problem, then you can use uric acid, uricosurics, and those are Benamid and lesinurad. So we're either going to cut down on production, which is preferred, or we're going to increase excretion. Increasing excretion is harder. So we'll talk about it with the different drugs. If you put somebody on a preventative dose to decrease their uric acid production, you will often induce a flare. Okay? So a couple of things you can do. One is that you can wait a couple of weeks after an attack has occurred and then start the medication. Or what we usually do is we start the medicine, either the allopurinol or the probenecid, if that's what we're going to use. We're going to start allopurinol, then we will start it with an anti-inflammatory agent. So we'll start it with a non-steroidal or colchicine, usually, to prevent the flare. As you lower that uric acid level in the blood, what happens is those uric acid crystal deposits start to dissolve. And they move around the body, and unless you can get rid of them at the same rate, then they will precipitate out in other places and cause a gout attack. This is so common, it's predictable. I see it happen, I used to see it happen quite often. Most people know now to do that. So if you start uric acid lowering drug, start a anti-inflammatory with it. I've skipped ahead, this is on the next page. Everything I'm saying to you is written down, it's just I'm going out of order. Once we start a preventative uric acid lowering agent, it's usually indefinite, unless there's something that has changed. And let's say they're on chemotherapy, they're undergoing cancer treatment that is causing their high uric acid levels. Once that's complete, you may be able to take them off. But most of the patients you're going to see and deal with, it's going to be long-term. Top of page 14. So the monitoring is pretty simple. You're going to monitor uric acid, treat them down to that level that we talked about. Uric acid less than 6, 5 if need be. If they have tophi, then you're going to follow the resolution of those over time. Usually that'll be radiographic. And the other is you're going to monitor for side effects, like you would for any drug, any treatment that you start. Okay. So the acute gout prophylaxis is what I kind of got ahead of myself. So you start an agent to lower their uric acid, you're going to start either a non-steroidal or a colchicine, either one. We use low doses of both. You can use colchicine 0.6 once or twice a day. It's usually very tolerable. Or you can put them on a low-dose non-steroidal. It would be, you would not use a steroid unless you can't, because you have to use it long-term. So it's the problem with using a steroid is that usually we will overlap this treatment, the prophylaxis, with the preventative for about 6 months. If they have tophi and we are continuing to get them to resolve, we may even go longer with the acute prophylaxis. And I've given you at the bottom of that page the length of time to do it. Sometimes that even when you start like the allopurinol, they'll continue to have flares and symptoms. So we're going to continue that anti-inflammatory during that period. But usually we're going to go at least 6 months. If we're trying to resolve tophi, then we may go 9 to 12 months past in order to prevent an acute attack. Okay. So the third bullet is treat for 3 months after having achieved the target serum rate. And there's no tophi then detected on physical exam. So these are usually folks that have small ones or they have a very limited number. The last one is treat 6 months after achieving your uric acid level, which is less than 6. And this would be usually when people have got more than 1 tophi and they're on the larger side. Sometimes they have to be surgically removed. They will get so big, there's no way to resolve them with drug. But that's for others to talk to you about. Okay, questions there. That's the outline. It's fairly simple, fairly straightforward. So let's talk about the drugs, and I'll reemphasize those points as we go through. So at the top of page 15, the monooxidase inhibitors, this is your preferred go-to. It would be the drug you would consider unless there are contraindications. Okay? So allopurinol is going to be your first one. It's been around forever. We know how to use it, and it's cheap. I think it's on the $4 list at Walmart, so it's very inexpensive compared to the Uloric, which is at the bottom. I think I put dose in there. $10 a month for allopurinol, $180 a month for Uloric. Okay. With allopurinol, we start low, and you would with any of these, is start with the lowest dose and move up. If you start on a higher dose, the likelihood of having a flare increases. So we usually start with 100 milligrams a day. The one thing you want to look at is what their renal function is. That will slow down how fast you titrate, and the dosing increases that you would use. The average dose for most people is 300 milligrams a day. And that's why a lot of people just go to that. They'll just start them on 300 because that's where most people will end up. You can dose it up as high as 800. Most people won't need that. They'll usually be in that 300 milligram range. The drug has an active metabolite which is responsible for most of its action called oxypurinol. It's very, very long acting, 24-hour half-life. So usually you can get away with dosing the drug once a day. They recommend, the manufacturer does, is that once you're above 300, then you break it into 2 doses a day. Let's look at adverse effects. For the most part, this drug is very well tolerated. It'll upset stomach like any other drug can. The one thing to keep in mind is that it does have a fatal hypersensitivity reaction. This is really important. People who are most likely to have this are of Asian descent. Chinese are probably at the highest risk, and it's the Han Chinese. My Chinese friends tell me that 80% of Chinese people are Han descent. So I would assume that they are going to have the genetic predisposition to this. Thai patients, Koreans, and those with low renal function are even more because the drug hangs around longer. So you can test for this. You can do an HLA testing with that B5801. Or you can use another drug. Now that we have Uloric, which doesn't cause that, you could use Uloric instead. So you can test them, use the drug if it's reasonable, or use the Uloric. It's a fairly high percentage of people who have that allele that are going to have that reaction. So keep that in mind when you see patients of Asian descent. Questions on the allopurinol? Okay. So you decide that a person needs preventative therapy because they've had multiple attacks in a year, or they've got tophi. You start them on this drug, and at the same time you put them on a non-steroidal or colchicine. And you're going to continue that for at least 6 months. You're going to monitor their uric acid levels. You can do it you could do it in 4 weeks. It doesn't take long for this drug to start to bring down that uric acid. But as you're doing that, you know that they're at increased risk of flares. You can either give them drugs to initiate at home or tell them that as soon as they have a flare, they need to get in to see somebody. What I would see the doctors I worked with was mostly give people stuff to start at home. They'd call in and say, okay, this is what's happening, confirm continuation of therapy. Uloric, if you've got someone who has a contraindication to allopurinol, you can use this. It does not have to be adjusted in renal insufficiency as much as allopurinol does. So unless you're below 30 mils per minute with a creatinine clearance, this drug has an advantage in that there. It does have more drug interactions, so that makes it a little bit harder to use. But most of the drugs that it interacts with, we don't use very often, unless you're dealing with cancer, and that could be where the mercaptopurine or the azathioprine comes in. In that situation, you would have to adjust the dose of the drug or use a different agent. The last concept is in small print at the bottom. When somebody is having an acute attack, you never stop the preventative medicine. Okay? So it's chronic, chronic, chronic treatment. Flare, you treat the flare on top of the chronic. Okay. If you stop the chronic, they'll flare more. So unless they're having a side effect or something else has happened that makes it in their best interest to remove it, of course remove it. But if everything is, if they're doing okay, then you leave them on the preventative, treat the acute on top of that. Questions? So when you see these folks, you're going to see them back more often in the beginning because you're going to be increasing their dose. Because 100 won't cut it on most people unless they're in the 8, maybe 8.5 uric acid and they're an older patient. 100 ain't going to do it. For most people, most of the time you're going to see people in their 40s and 50s, early 60s where this is going to happen to them. Because that's when their hypertension, the drugs that you're going to use, their diabetes is first diagnosed. That's where you're going to mostly see this group. Could see it in people predisposed that are younger that drink a lot. That also can be a time when it would happen. The uricosurics, they're very interesting. You would think, well, this seems like the drug to use. But they're not as powerful in terms of the production side of it. And they have a lot of contraindications. Or they have some contraindications that don't make them as useful. So I told you you're usually going to see this in older folks, middle-aged to older, and the probenecid just isn't that as effective as you get over 60, or your renal function goes down. So you'll see two different things there. Don't use it in people whose creatinine clearance is less than 50, or don't only use it in people whose creatinine clearance is above 60. So the number doesn't matter so much as in that 50 to 60 range. Don't start it or stop it and use another drug. So that's what makes it less powerful or robust of a drug in the treatment of gout. Let's see. So it should only be used in younger patients that are under excretors, which means you'd have to do a test to figure that out. Most of the time people don't. They're not going to determine if you're an overproducer under excretor. You just won't do that. You'll put them on something like allopurinol because it doesn't matter whether you overproduce or under excrete, because the drug can stop you from producing it to a great extent. If they have a history of kidney stones, you're just going to increase the problem because it will increase the amount of uric acid that gets goes through the kidneys. Also those who are on aspirin or diuretic therapy, because it'll just compound the problem. It'll increase their flares. We don't see this very often if you look under the drug interactions, but people who use large doses of aspirin. Now you might start thinking about your headache folks or your migraine folks, because I can't think of any other place where we use a lot of aspirin anymore. We used to for rheumatoid, juvenile arthritis. That was our go-to drug, but we have others now, so we don't use high-dose aspirin as much. But if people have used a lot of aspirin, this drug would be contraindicated because they interfere with the excretion of the drug. It's the interaction between the drug itself, not so much on the uric acid. Beta-lactams are eliminated through the kidneys through the same transport mechanism. So if you use probenecid with them, it raises the dose or the circulating amount of the penicillin. What else is down there? The sulfonylureas, this is a protein binding problem, so it just increases the amount of sulfonylurea that's available to exert an effect. As we saw with the allopurinol, we don't stop it during an acute attack. So if they're on it as preventive, you continue it and treat the acute on top of it. Questions about probenecid? You won't see it used very often, but it is something in your arsenal or toolbox that you could use. Now the one you might start using more, this is an interesting, this lesinurad, actually it's a uric acid transporter blocker. So remember those enzymes or those transport systems they showed you, the urate 1 and the O4, I think is O4. So these are involved in uric acid reabsorption. This drug inhibits those. So it allows more uric acid just to pass through out into the urine. This drug is never used by itself. It's used in combination with usually allopurinol or the other xanthine oxidase inhibitors. Okay? So I can see it being a very powerful drug in people who you can't increase the dose of allopurinol or who are not getting adequate effect from the use of just a xanthine oxidase inhibitor. This would probably be very helpful in the cancer patients because they get huge uric acid loads and burdens. So it's going to be expensive, but I could see a real value for this drug. Okay. On page 17, Krystexxa, pegloticase, interesting drug. It is a uricosuric. If you look on the little picture there to the side, it mimics the action of uricase, which is an enzyme that converts uric acid into allantoin, which most animals can do. So that's why your animals don't get gout, is because they can go ahead and metabolize the gout into a water-soluble product that just gets peed out. So this drug is, unless you're dealing with really severe and advanced cases of gout, when people have lots of tophi or gouty arthropathies, you won't see this, but it's extremely powerful. It's IV, so it has to be given in the office, and it's, if you look at the bottom of the page, I pulled this off the internet. This is supposedly a guy who had 5 treatments, so about 3 months probably worth of this drug. And you see the tophi in his hands in A, and now you see in B the resolution of those. So very powerful drug, expensive. But you see after 6 months of therapy, 45% of patients achieve complete resolution of tophi. That's powerful. So you have to pre-medicate them with antihistamines and steroids because of the infusion reactions. But for the most part, it's one to keep in mind for people who are who have lots of tophi. Oh, the one contraindication, need to point it out, is can't use it in patients who have G6PD deficiency. So you'll get hemolytic anemia if you use it in those folks. So screening them, particularly high-risk patients for that, is important before you give the drug. Questions there? Okay, page 18, colchicine. So we talked about having a narrow therapeutic index. Everybody you give it to will have side effects. They'll all get sick to their stomach, some of them may vomit, and they'll get diarrhea. It happens in almost everybody. I've talked, under mechanism, I talked to you about its action on the microtubules. So it interrupts that cycle of tubule dimers being converted into microtubules. Placement therapy, treatment of acute gout, it's very effective, and also for prophylactic, so either one. And I've gone over the dose already. We've gone over the interactions. There's pictures at the bottom to kind of show you the dosing for acute and then chronic. And that's it. I'm not going to talk about the steroids or the non-steroidals. You've had it before. We've talked about them. It's there for your review. You're responsible for them as much as what's in the objectives. So questions about the treatment of gout. Pretty straightforward, pretty easy. Okay. Let's talk about osteoarthritis. This one will be quick. I can do it in 15 minutes. So osteoarthritis, what do you know about it? Oh, I think I have a video.
If you write anything on your computer, you need to get Grammarly.
I write pretty much all day, every day.
Bones provide support for the body and aid in its movement. The place where two or more bones meet is called a joint. Joints may be immovable,
Okay.
slightly movable, or freely movable.
Be glad you know something.
A synovial membrane surrounds movable joints. Inside the membrane, synovial fluid lubricates and nourishes joint tissue, such as cartilage. Articular cartilage is a tough, slippery covering on the ends of the bones, which allows smooth joint movement. Joints give the body flexibility, precision of movement, and help in supporting the body's weight. Arthritis is any disorder that affects joints. It can cause pain and inflammation. Osteoarthritis, or degenerative joint disease, is the most common type of arthritis. It's usually seen in older people. The joints most commonly affected are in the hands, knees, hips, and spine. Often the cause of osteoarthritis is unknown, but it may be due to a combination of the following risk factors. A family tendency for this condition. Being overweight. A joint injury such as a fracture. Repetitive strain from activities such as sports. And problems with the bones in a joint not lining up properly. Over many years, these factors can wear away the articular cartilage. The exposed bony surfaces rub together. This, along with the growth of bony projections called bone spurs, causes swelling, pain, and limited movement of the joints. There is no cure for osteoarthritis, but a combination of treatment options control the symptoms. For example, medications can reduce joint inflammation and pain. Common medications include acetaminophen and non-steroidal anti-inflammatory drugs, or NSAIDs. An ice pack may also reduce joint pain. Lifestyle changes, such as resting the affected joint and losing weight if necessary, may help slow down the progression of osteoarthritis. Other lifestyle changes include physical therapy exercises and education to manage osteoarthritis on your own. Physical therapy exercises, along with low-impact exercise such as walking and swimming, increases muscle strength and keeps joints limber. Braces can help with joint support and alignment to reduce joint pain. Another treatment option is the injection of hyaluronic acid into the joint. Hyaluronic acid is a naturally occurring substance in the joint's synovial fluid. It helps lubricate the joint and allows the bones to slide over each other more easily. For severe osteoarthritis, a doctor may recommend a surgical procedure, such as joint resurfacing, to remove loose bone or cartilage and bone spurs. Or an osteotomy or bone removal may be recommended to realign deformed joints. In some cases, the arthritic joint may need to be replaced with an artificial joint. For more information, talk to a healthcare provider.
I would imagine you've had some interaction with people who have osteoarthritis. Yes? Yes. This will be be the bane of your existence if you are treating adults with chronic diseases, because the more osteoarthritis they have, the less they can move. The less that they can move, the less they can control their disease. It's a big problem in diabetes. The heavier people get, they get to a point where they can't move enough to then move the excess weight off. So this is a real problem. You will see this over and over again. The big thing is educating patients early on in lifestyle, getting them in with a physical therapist, encouraging them in exercise and lifestyle changes that will remove or reduce the wear and tear on those joints. Those are all listed there. The drug therapy comes at the end if everything else doesn't work. So really employing those non-drug therapies is important. Weight loss, of course. I've given you some stats there. Just a 5% loss from baseline. Not a lot. I've told you that often small things make big differences. So 5% is usually something people think can grasp onto. If you weigh 200 pounds, then that's, what, 10 pounds. So it's usually within the realm, instead of telling people you've got to get down to your ideal body weight, which won't count. Excessive weight, at least from the group that I was reading, it said is the single best predictor for the need for eventual joint replacement. I have two good friends that are orthopedics, orthopods. The one told me he felt that the biggest predictor is the alignment of the joint. He said if the joint doesn't align, you can almost guarantee that person will eventually need a replacement. Because I was asking him, how come some heavy people never have joint replacement and some do? And he said he thinks it's the joint alignments, and he's done it. Lots of replacements. So that was his take on it, an N of 1. Aerobic exercise, looking and promoting those things that are non-weight bearing, so like swimming, is great. It's just hard for people to get access to sometime. Elliptical training, cycling, upper body exercises, so getting them into a gym or with a trainer or with a physical therapist who can help them. The quadricep training, I gave you one of the exercises. Most of the quad training is fairly easy. If you Google it, you can find a lot of YouTubes that you could show patients or give them a handout. So those are fairly easy to do, and a lot of them can be done seated. I've done two. I'll post this on to D2L. I've given you two things about isometric exercise because I wasn't sure myself. So I gave you two videos that explain the difference between isometric and isotonic. We prefer isometric because it's not as hard on the joints. Know where your physical therapists are. Your occupational therapists can do a lot to help people be more mobile because they can teach them life skills that will allow them to move around in their environment for maximal flexibility and also the ability to do their task of daily living. I put the TENS unit here as effective in some cases. I read another group, and at the end I didn't catch this, who felt like it really did not have enough data behind it to support its use. So in terms of drug therapy, this has changed a little bit in the last few years and different from what he's told you in the video. Don't go by what he has said in terms of drug therapy. More wanted you just to see the pathophys. So in terms of mild osteoarthritis, the lifestyle stuff is going to be huge. Here our focus would be topical non-steroidals. Okay. It used to be acetaminophen. People have moved away from that because of just the problems with the amount of acetaminophen and its availability in multiple products, the concern about that, and it's minimal in terms of pain management. So the topicals are preferred. The good thing here is that all the contraindications to non-steroidals are not so much of a problem. We're not put in the GI tract, so GI problems become less of a problem. The absorption is low, so the effects on cardiovascular and kidney are low. So the risk is low with this group. Diclofenac has the most products out on the market that can be used here. They make creams, gels, a patch, and solution. Gels are probably by far the more common used. Ketoprofen also has a cream that is available. So they can be applied 2 to 4 times a day. You do have to get concerned if patients are putting it over large parts of their body. So if they're limited to joints, then they're probably okay. If they have multiple joints, you need to think a different pathway, probably an oral agent. Don't want you to use this in combination with an oral, so don't use an oral non-steroidal with a topical. I see some concerned faces. Any questions on the back? So this is mild. The other thing you could look at using is on top of page 5 is capsaicin. We talked about this when we looked at neuropathies in diabetics. So this is an agent, comes from peppers, hot peppers, and it depletes substance P, which is a neurotransmitter involved in pain transmission. So this is available over the counter. You can get it as a cream, a patch, those are the two I'm familiar with, a lotion, gels. The problem here is that it takes a couple of weeks of use before you see maximal effect because of the need to deplete substance P. The other, I want you to keep it in mind because patients can go and buy it over the counter. There's no prescription to this that I know of, so they can go out and buy it. And it's promoted for this. And they may see it as natural versus what you give them as being medical or unnatural drug. So keep it in mind and ask about it. They're fairly well tolerated. There aren't a lot of contraindications to it. The biggest thing is getting it in a mucous membrane because it'll just burn the fire out of you. They'll never do it again. But washing their hands before they touch their face or any other mucous membranes would be important because it's very, very irritating. So for mild, it may be a good way to go for patients. I put the counter irritants down here as well because people may use them. They probably are very minimally effective, but they've been out a long time, and so people may feel a comfort of going to those. They may have gotten benefit in the past, but they're old, as they get older, they may lose benefit. So menthol, methyl salicylate, camphor, these are what we call counter irritants. It goes to the gate theory, is that your brain can only process one thing at a time. If you make it think about a counter irritant, it can't think about the pain. Okay? So if we give you, if your head's hurting and we punch in the arm, you're going to worry about the arm for a while before you worry about your head. It's that kind of thinking. So for the most part, as long as they're used as directed, there is no problem for them doing that. Now, the methyl salicylate could be a problem because you can absorb quite a bit of salicylate out of it. So depending on what else they're using, I might switch them to or steer them to a different product. Questions about those? Yes, Amy.
Does capsaicin work just as well as the diclofenac gel, or is it maybe milder in terms of?
I don't know of head-to-heads, so I can't tell you. For very mild, I would think they're probably going to be fairly equal. And probably those things are more self-limiting anyway. So I don't know. I can't tell you based on, I don't think there's any studies out there. But I didn't look specifically. I can't. The last are moderate to severe. Here the pharmacologic treatment is going to be an oral non-steroidal. So everything we've talked about before is going to be the same here in terms of adverse effects. You're going to look at, see, is the person a high GI risk or are they a high cardiovascular risk? If they're neither one, you can treat them with the amount of drug that it takes to control symptoms. If they're a GI risk, then you may want to consider using a selective COX-2 like Celebrex. If they're very high risk GI, then put a PPI with it, put a proton pump inhibitor. If you can't use the COX-2, then use a non-selective with a proton pump inhibitor. If they're cardiovascular risk, then naproxen has been touted in the past to be a safer one, but that has been called into question as well. So using non-steroidals in patients at high risk is long-term is problematic. The renal effects, I've listed there for you. Remember them. Remember your people who is at highest risk for for nephrotoxicity from the non-steroidals. All of this we've been over before. Just a reminder that Celebrex is a sulfonamide, has a nucleus that's similar to the sulfa antibiotics, so you can't have cross-reactivity. They can also have an allergic reaction. I would only avoid it in those who've had like a life-threatening, they've had anaphylaxis. Platelet function, same thing there. COX-2s might be better if you've got somebody on a anticoagulant that you're worried about bleeding. If you look on page 8, there's only a couple of other considerations, and then the rest, and now I'll talk about glucosamine. Unlike, if you give me 5 minutes, I can get done. Duloxetine Cymbalta, we've talked about it also for diabetic neuropathy. If you have people who cannot use a non-steroidal, this is an agent to consider. It has really good data behind it in terms of neuropathic pain. And it has some data behind it in using it for osteoarthritis. So it might be a possibility. The other are the intra-articular use of glucocorticoids. So in the past, this has really been discouraged because we have felt that the use of intra-articular steroids would decrease or would damage cartilage over time. The authors that I read seem to feel that there's not enough data to stand behind that, so the judicious use of a steroid injection into a joint is reasonable. I think they put down no more than 3 to 4 times a year. This is going to be one of your more last resorts. This may be people who are not ready for a knee replacement, but they can't use a non-steroidal, or they just have one joint that bothers them, or they can't get relief from the drugs that you have tried already. We use triamcinolone again. This hexoacetylide, that salt tends to stay in the joint. It doesn't tend to get absorbed as much. You still will get systemic absorption, but it tends to stay put more. So it might be one to consider over other salts, the triamcinolone salts. It will raise blood sugar. Just keep that in mind. Anytime you inject steroids into some part of the body, their blood sugars are going to go up. You can see there that the relief is pretty good within 24 to 72 hours, and it can last up to 8 weeks. So something to keep in mind. The hyaluronic acid that he mentioned has been something that people put hopes on, and it has been popular. It's very expensive, but it has very little data to show that it does anything. So I would say don't consider it. And then at the bottom, the glucosamine chondroitin. This is another over-the-counter. Lots of your people will use it. It's expensive, but a lot of people swear by it. The data behind it is that there is probably some use to using it, and the glucosamine part is probably what is helping, but it's minimal. But if people are getting effects, then they recommend just leaving them on it if they feel like they're getting a benefit. I will tell you that just from watching patients over time, glucosamine will raise their blood sugar. So people who are diabetic, if they were really set on using it, then we just monitored their blood sugar and adjusted their doses of other drugs to compensate for that. The chondroitin does come from shellfish carapace, so if you have people who are allergic to shellfish, then they would probably need to stay away from that. Questions? Oh, one thing I want to point out is there is, down in about the second bullet, is that glucosamine is available, glucosamine hydrochloride over the counter. It's not effective, don't recommend it. So it's the products that are that are the glucosamine sulfate with the chondroitin. Questions? Yes.
Chlorine injections, like, I know they don't smoke it, but I used to get like smoke injections, so
Oh, no, I don't know.
they might be the same.
Yes, more than likely.
They help me. That was one of those, like,
Could be with you, you're younger, but if you look at the big studies, it's not.